Hello, everybody. I'm just going to go through this morning some examples to demonstrate the hard work on everybody's behalf, not just at the HPO, but on behalf of all our colleagues in HYPE in the hospitals, and the clinicians and the finance people, and that kind of working together that we're seeing more and more of now. So we just wanted to try and demonstrate some examples of that. So, okay. This is just an overview of the AOR-DRG profile across ABF hospitals for inpatients 2014 to 2016. Now, it's good to see that in that time frame, this is the severity split here. So, sorry, better get my laser. A are the most complex, the highest severity in a DRG. B is the next to highest. C is the third to highest. And then D is the lower complexity. So these have, the Z DRGs are not included in this. But what we're seeing is that there is a gradual shift towards an increase in complexity, and that's what we want to see. We don't want to see a dramatic shift into those A DRGs, those really high complexities. And it's building up our knowledge all the time of monitoring and keeping an eye on how those severity splits are happening. So it's very interesting. We've moved from 13.3 up to 14.5 in 2016. The B DRGs have pretty much stayed the same, and we see some decrease around the Cs and the Ds. Now, as I said, the Zs have been excluded, and this is purely for ABF hospitals. So that's a good starting point. It is gradual, and we did have an increase in activity in 2016 compared to 2014. So all the time we're getting more and more data in, up from about 1.6 million records in 2014 up to around 1.7 million in 2016. And it'll be very interesting to see as well how that will change when we start looking at 2017 data in the 8th edition grouper. So it's just that profiling to make sure everything is going as expected. So this is an example of one hospital, and while the shift at a national level might be quite subtle, at individual hospital level, through the activities of the hospital and the HPO and the clinicians and everybody involved, we're seeing some real improvements in the quality of the data at individual hospital level. And in some hospitals it's quite significant. So in this particular hospital, the number of DRGs that went into an A severity level increased from 10.4 up to 15.3, and that's what we would have expected in that hospital given the activities that they were undertaking and the work that they were doing on their quality and their training of coders. Now, my next slide, Brian Donovan had as well, so I'm only briefly going to mention this because I have a more interesting one for us HYPE people next. So showing that this shift towards the higher complexity in the stroke DRG at individual at hospital level, ABF hospitals, and then compared to that highest complexity hospital. So all the time this is going up, but not every case will go into an A complexity DRG. So we have to make sure that that's appropriate and correct and as it should be. And with the efforts that we have going into the quality of the data behind the scenes, when we look at this kind of data now, we're able to say that yes, we're happy with the quality of the data in behind this change. So I just drilled in a little bit, and thanks to all my colleagues in the HPO for providing these graphs and tables and the data behind them. So we just drilled in a little bit. So if we look at strokes, so I-64, coders will know that code. It's a very vague code for stroke, not specified as hemorrhagic or infarction, whereas I-63 is cerebral infarction. And in 2015, our number of vague stroke codes was about 469, and this is at 450 in 2016. But the overall number of strokes has increased. So we have an increase of about 200 cases, but yet we're still seeing that quality improvement around the specificity of the coding of the strokes. And we're doing more and more work on that, and my colleague Deirdre Murphy will talk more to that later on. So I just put in a little look at 2017 there because it's preliminary. And again, we can see that the less specific code is shrinking all the time. So this is just an example of looking at a DRG. This is E75, which is other respiratory system diagnosis. And the main driver for this DRG is nothing very exciting or dramatic. It's acute lower respiratory tract infection. That's how most of the cases get into this DRG. But we've seen over a 2,500 increase in activity in this DRG between 2014 and 2016. So again, the numbers have gone up, but we're seeing that the improvements are happening around the additional diagnosis and increasing the complexity of the coding of those cases. So the A's have gone up now by just over 2%, from 12% to 14.6%. The B's have come down and the C's have stayed about the same. So while the principal diagnosis, for those cases, it might not be very dramatic or exciting or high acuity, but it is a big volume. There was, in 2016, there's over 17,000 cases assigned to E75, so it's fairly high volume. So Deirdre will talk a little bit more about this, but with the National Sepsis Programme, we're seeing an increase in the reporting of sepsis. This slide is actually taken from the Sepsis Programme's annual report. And you can see all the time those figures are going up and up and up for sepsis. Now, there's a number of reasons for that. There's, better awareness amongst clinicians. There's the clinical program. And also in terms of coding, in 2015, we moved to a new edition of the classification, and that brought with it a whole improvement in the codes available for sepsis and the guidelines around the coding of sepsis. So now we have codes for SIRS, sepsis, septic shock, and very strong guidelines to back up the use of those codes. And we're working very closely with the programme. And it'll be very interesting in 2016 to see how that goes up even further. So just to look, I just ran one report on discharges with the code of SIRS, which is Systemic Inflammatory Response Syndrome, or 65. Now, there are a number of codes in that category. It's not just the, sepsis-related ones. There's ones related to non-infectious origin. There's a number of SIRS codes. But we can see the dramatic increase there in 2015. We had about 300 discharges reporting any diagnosis of SIRS. In 2016, that's up over 2,000 reporting any diagnosis of SIRS. So you can see how those quality improvements through working together are really driving. We can now see this in the data at DRG level, hospital level. Even when we go into code level, we can really see those improvements coming through in the data. James spoke a little bit about condition onset flag in Australia. In Ireland, we call that the hospital-acquired diagnosis. And Deirdre had looked at this in some detail. So we can see the improved reporting in Ireland of the hospital-acquired diagnosis. We first introduced it in 2011, so you can see all the time that's going up and up. And in 2015, we updated the classification, and there were some new guidelines around the use of that hospital-acquired diagnosis code in 2015, so we can see that coming through in the data. And also, as well as that, coders would have been through a whole range of training and education at that time when we introduced the classification. So we would have always been trying to raise awareness with coders and with clinicians around the importance of capturing that hospital-acquired diagnosis. Now, it's interesting to note that at the moment, 2016, we have over 10% of discharges reporting a hospital-acquired diagnosis flag. That equates to about 72,500 discharges. Okay, now bear in mind that this is something that coders pick up themselves. It is not indicated in a chart, ticked. There's nothing ticked in the chart. The coders interpret this from the clinical information where they are sure that a condition has first arisen after admission. And this is a quote from an Australian publication. So the health policy analysis from the Australian Commission on Safety and Quality in Healthcare. And they say in Australia, for hospitals reporting the condition onset flag, which is their equivalent, an estimated 10% of episodes have at least one hospital-acquired diagnosis reported. So we can see that we are in line there with that. Okay, so that's really coming through now on the data. Now the next slide, this is, I want to spend a minute or two on this slide because I really think this is important, and I just think it's very interesting. If you think back to where we started at the A or D or G profile, so the A is the most severe, B is the next up, and so on, and I've Zs included here. So this slide is all about A or D or G profile. In 2015, we had the external review of HYPE data performed by Pavilion Health from Australia, and they conducted chart-based audit across 10 sites, looking at just over 1,400 records. The original coding is what our original Irish coders, that's the profile of the D or Gs assigned by that original coding. And this is the D or G profile by those Australian coders from what was re-abstracted for that Pavilion Health. So you can see the correlation is absolutely fantastic there between the A or D or G profile. Now within that there would have been variation. Some hospitals had great results, some hospitals had more differences. But it's really good in terms of quality sure data, and this was based on 2014 HYPE data. So even at that time, when we were starting out on this journey of really ramping up data quality, we were pretty much in line with what those Australian external auditors found. And what we have now done, because we have ramped up that work in the HPO, I have compared that to a cumulative results of our HPO audits. We've also included 10 of these in this. We've done 10 to date since the Pavilion. So I've included those here. And again, the A or D or G profile. So this is the original coding by the hospital coders, and this is the HPO auditors coming in. And again, you can see that correlation. So again, this was 2014 data. The audit was conducted in 2015. And this is 2016 to 2017. There was a bias towards more complex cases in the sample for this audit. So that's why the A's are slightly higher for this. But it's just a really interesting data quality assurance piece that our A or D or G profile is as we are finding it in chart-based audit, which is considered the gold standard. And as the external auditors also found it. That's not to say there weren't changes, but just when you look at an A or D or G profile, it's very reassuring. These are our suite of tools that we have. Our data quality starts the minute the coder enters the case onto the HYPE portal. They have their data entry edits. We have the checker program. We have an audit toolkit. We have the HYPE reporter, which allows for interrogation and reporting on HYPE data. And as Brian mentioned, we have the ClickView tool now and the benchmark report. So dealing with this big data, the tools are there. So it's to start looking at it and using it. Just to mention as well that we have got the checker and HCAT and coding help desk in the breakout room at lunchtime as well. This is the hospital use of the checker tool. So this is where we stand at the moment with hospitals using the checker tool. Now we've 38 hospitals have used it within the last month. This is a tool that's freely available and there for all hospitals to use. But we found that 7 hospitals have used it within the last 3 months, but not within the last month. And 7 hospitals, it's been more than 3 months since they've used it. So these are the types of things that we have to monitor now at a national level to make sure that that data quality piece stays happening, and we have that. And the hospitals have really taken on board this work. So we're really trying to work with hospitals to get them using the tools regularly, and that is a big change in 2 years for the hospitals, that amount of hospitals to be using these tools on a regular monthly basis. So we're going to be publishing our data quality strategy soon, hopefully, and this will set out the role of the hospital and the role of the HPO in terms of data quality. What do we expect of hospitals, and what are we expected at the HPO to do? So it's working together and it's feeding those things into each other. And as we've ramped up all our data quality work and our resources at national level and at hospital and group level, we see that that's getting more and more attention as well. So now we need a strategy that can kind of drive that forward so that at next year's conference we can have some more highlights to report back to you. But we do acknowledge absolutely the data quality work being undertaken by hospitals. We can see that all the time, and whenever we go to a hospital, we can hear about it. And it is a joint effort between the clinician and a coder, and that's what the data quality is all about. We can't do it on our own, and we can't reflect the clinical practice on our own. We need the clinicians to be involved in that conversation. So I'm going to hand you over to my colleague Deirdre Murphy now. Thank you.